High-grade listhesis has been defined 50% displacement or listhesis with measuring grade 3 or higher. There are various techniques have been used, right from Harrington rod to external fixator to combine anterior and posterior approaches, Boltzmann and reverse Boltzmann techniques, translation techniques, in situ fusions. So we aim to do a clinical, surgical, and radiological outcome study of MIS relief in 24 patients. Patients who with back pain, leg pain, and patients with neurodeficit were included in the study. Patients with disc disease, multi-level, neoplastic condition, and infection and trauma were excluded. Study was conducted at Kokilaben Institute from 2017 to 18. It was a retrospective type of study. 24 patients were studied for minimum follow-up of 2 years. We used VAS score, ODI score, and SF36 scores. We used history, clinical examination, VAS and ODI, X-ray and MRI for pre-op evaluation. This is the position of the patient on the Jackson table. Head-eye position was given on L5S1 disc to orient the disc space vertical so that there will be a better handling of the instruments. As seen in the X-ray here, a dynamic grade listhesis gets reduced by 1 just with the position of the patient. Coming to the techniques, approximately 2.5 centimeter incision was made 3 centimeter away from the midline. Tubular retractors were deployed. Fascectomy was done. Decompression done under microscopic magnification. Over the top decompression is done with in rigid cases. A 10 by 4 mm piece is removed from the sacral body with the use of kerosene punches to access the L5S1 disc space. Pain-filled retractors were used to confirm the space. In reducible listhesis, normal T-leaf cases protocol is followed. In rigid cases, 1 mm, 2 mm kerosene punches were used to prepare the end plate. These are the various curates which were used. To help the retraction, various pucas were used, which will help in ligamento-taxics and get the better effect from the annulus, PLL, and ALL retractions. Trial gauges were used. In rigid cases, bilateral fascectomy was performed in same fashion. In initial 14 cases, percutaneous screws were inserted. In later 10 cases, OM is used, which helped in medial and more lateral entries to give better access and longer and stouter screws. The final position and lordotic cages were put, and the final position is checked on the C-arm. Immediate post-op care, patients were mobilized on the same day. None of the patients had any neurodeficit. Most of the patients were discharged on the post-op day 2. One of the patients had dural injury, which was sealed with fibrin sealant. None of the patients had any complications associated with blood neurodeficit or blood loss. None of the patients need any open procedure. These are the few cases showing final fusion. Another case, high grade, showing good fusion. Interesting case, 4th revision, operated with MIS, giving good results. Coming to the results, we had operative time of 144 minutes, blood loss 1 at 2, hospital stay at 2.2 days. We have shown significant improvement in the VAS score, ODI score, both the components of SF36, mental and physical. There was significant improvement in the sleep angle, disc height, and foraminal height in the high-grade listhesis. We achieved Breedwell grade 1 fusion in all 24 patients. There was significant controversies existing between open and MIS, and Foley's, as per Foley's, the MIS has been superseded, the open. Our results were equivocal with Shuffleberg et al., Jarajkumar et al., and Goels et al. Considering the less blood loss, operative time, and post-operative hospital stay, faster recovery is associated with MIS surgeries. This is due to the less muscle retraction and morbidities associated with MIS surgeries. Although we have limitation, it's a single surgeon experience, and follow-up is varied from 2 to 4 years. Coming to the conclusion, MIS is a good way to do high-grade listhesis. Thank you.